In this video, we are going to learn about a very important topic, alcoholic liver disease. Now, alcoholic liver disease is basically a progressive liver damage which is caused by the chronic alcohol consumption. Okay, and we know that after cardiovascular diseases and diabetes mellitus, this is probably the third most important cause of morbidity and mortality all across the world. So, alcoholic liver disease, if you see, is a spectrum disease. So, it starts with a fatty liver, progresses to alcoholic hepatitis, and then to alcoholic cirrhosis. So, basically, if you see, there are three stages of alcoholic liver diseases. The first is fatty liver, also called as steatosis. So, in this stage, there is a reversible accumulation of fat in the hepatocyte. So, remember very importantly that this is a reversible stage where there is an accumulation of fat in the liver. The second stage is basically alcoholic hepatitis. So, here there is an inflammation and necrosis of the hepatocytes. Okay, so whatever is the effect of this fat and other toxins, this leads to the inflammation and necrosis of the hepatic cells. Also, remember that this is also a reversible stage, but here along with the liver damage, you will have some systemic manifestations coming. Okay, in the first stage, there were no systemic manifestation, and the third stage is basically alcoholic cirrhosis. So, it is basically the irreversible stage, and here there is fibrosis and scarring of the liver along with severe liver dysfunction. Okay, so these are the three stages of alcoholic liver diseases. Let's quickly look at what are the factor which will determine the progression of this alcoholic liver diseases from fatty liver to alcoholic hepatitis to alcoholic cirrhosis. So, there are multitude of factors, important being gender, quantity and quality of the alcohol consumed. Now, about gender, let me tell you, for male, almost 40 to 80 gram per day will lead to fatty liver. And if the amount quantity is increased to around 160 gram per day for an extended period of 10 to 12 years, then this may lead to alcoholic hepatitis. Okay. But if you see same for the female, even a quantity of 20 gram per day is enough to induce alcoholic fatty liver, and a slightly more will lead to alcoholic hepatitis. Now, this is primarily due to the BMI differences as well as due to the estrogen which is there in the female, which predisposes them to increased damage by the alcohol. The third is BMI, physical activity levels. Also, certain infections like hepatitis C may predispose or make it faster progression from hepatitis to cirrhosis. Also, remember dietary fibers, certain dietary fibers like use of coffee, okay, decrease in use of sugar, all these are again contributing factor. Also, the presence of NASH, that is non-alcoholic steatotic hepatitis. Okay, so if there is NASH, then again the progression from alcoholic hepatitis to cirrhosis will be faster. So these are the factors which will determine how faster from alcoholic liver disease will progress from fatty liver to alcoholic cirrhosis. Let's look at the pathogenesis. Now again, pathogenesis, I will try to describe the pathogenesis of, or what is the major pathological mechanism in each of these stages. Let's look at the first stage, that is the fatty liver stage. So what happens in fatty liver stage? We know ethanol with the help of alcohol dehydrogenase will be converted to acetaldehyde. Okay, and this again with the help of aldehyde dehydrogenase will be converted to acetate, and this acetate may go into various different metabolic pathway. Now there are a few things I'm going to mention to you. First of all, both these dehydrogenase means removal of this hydrogen. So this will lead to excess production of NADH. Okay, and we all know from our biochemistry that excess NADH will increase the fatty acid synthesis, will decrease the fatty acid breakdown, and also will lead to triglyceride accumulation. And all these three will lead to deposition of fat, reversible deposition of fat in the hepatocytes. So this is the mechanism of fatty liver. One more thing I want to mention here is this molecule acetaldehyde. This acetaldehyde is specifically toxic to the mitochondria. Okay, to the mitochondria of the hepatocytes, and this becomes very important. Why? Because the specific enzyme which is present in mitochondria is SGOT, also called as AST. Okay, whereas in the cytoplasm, so this is present in the mitochondria, whereas in the cytoplasm of a hepatocyte, okay, you will have SGPT or ALT. Now by this you will draw a conclusion that whenever there is a damage to the liver because of alcohol, SGOT, SGPT, SGOT or AST will increase much more as compared to SGPT, ALT. Okay, and that is why when I'm going to talk about the diagnostic parameters, we will see that SGOT by SGPT greater than 1 is a indicative of alcoholic liver disease. Is it clear? So remember, SGOT AST is found specifically in mitochondria, and we have seen that it is mitochondrial damage which happens more prominently in your alcoholic liver disease. So this is the pathogenesis of the fatty liver part. Let's look at what will happen when there is fatty liver progression to alcoholic hepatitis. So in this stage, what will happen? There is an enzyme called as MEOS, that is microsomal ethanol oxidation system. Okay, so this is activated, and what will activation of MEOS do? It will lead to the production of increased production of ROS, that is reactive oxygen stress or okay. So there will be increase in the oxidative stress, and this will lead to increased in production of pro. There will also be microvesicular fat deposition, and finally you will have Mallory-Denk bodies. So these are basically eosinophilic inclusions which can be seen in the cytoplasm. We'll show an image of this Mallory-Denk bodies. So this is what happens in alcoholic hepatitis. Let's move forward. Once there is a lot of inflammation, there is a lot of necrosis, this leads to the activation of stellate cells, and this is what will lead to fibrosis, both micronodular and let me quickly show you some images. So this is basically, you can see there is increased polymorphonucleosides. There is deposition of fat both inside the cell as well as here. So ballooning of cells and all those you can see in this. Okay, let me show you another slide which will help you to yeah. So this slide you can see. So obviously there is fat deposition, and you can see these eosinophilic deposits. So these are your Mallory-Denk bodies. Okay. Now can anyone tell me what are the differential diagnosis, or what are the different conditions where this Mallory-Denk bodies are found? So there are 5 conditions which I have to tell you. So remember, first is alcoholic liver disease or alcoholic liver hepatitis. Second is non-alcoholic steatotic hepatitis, that is NASH. Third will be W, Wilson's disease. I, Indian childhood cirrhosis. So basically, you know, in Indian households, poor household, copper vessels are, used to cook food, and you know, then the copper leaches into the food, and when the child, takes in that food, that leads to liver cirrhosis. And P is primary biliary cirrhosis. So these are the 5 conditions. Good mnemonic would be alcoholic, non-alcoholic, work in progress. Work in progress is just a way that, alcoholic liver disease is basically, a progressive disorder. So work in progress. Alcoholic, non-alcoholic, W is Wilson, I is Indian childhood cirrhosis, and P is primary biliary cirrhosis. So these are the various conditions where you can find Mallory-Denk bodies. So having learned the pathology, let's look at the clinical features. So most of the patients will be asymptomatic initially, okay, and the only complaint can be nausea, vomiting. Also, some patients may complain of right upper quadrant pain. History of alcohol intake will be there, okay. Then on examination, tender hepatomegaly will be there. Some patients may have jaundice, but that is generally towards the later stages. Okay, only when there is alcoholic hepatitis or in cirrhotic state, only jaundice. So bilirubin may be slightly increased or even normal. Also, once the features of alcoholic, hepatitis or cirrhotic sets in, and you will have features of portal vein hypertension, then a different set of symptoms may start appearing. For example, you can have patients of, in advanced cases, palmar edema, arrhythmia. Then you can have spider nevi, gynecomastia. Also you can have, you know variceal bleed or caput mucosae. And when, patients eventually will go into hepatorenal failure, so again, depending upon what feature, which stage the patient is coming to, you can have various different clinical features. Let's quickly look at what are the diagnostic tests and findings. So if you do a CBC, you will have macrocytic anemia and also thrombocytopenia. So why is this thrombocytopenia? Because in alcoholic liver disease, you will have hypersplenism. Okay. You can also have, decreased albumin. You can also have increased PTINR. You can also have, bilirubin. I told you bilirubin may be slightly increased or more increased depending upon what stage the patient is there. Now, there are certain questions which keep coming in, certain one-liners which keep coming in as for the diagnostic test in alcoholic hepatitis. Let me, mention them so that you can see the slight differences in these questions. So one question they ask is best marker for alcohol consumption. The correct answer will be gamma GGT. Okay. Now remember, this is the marker of alcohol consumption. So this is non-specific and it can be raised in any of the causes which can cause fatty liver. Any of the causes which can cause fatty liver can also lead to increase in gamma GGT. But this is the one of the best markers for alcohol consumption. Another question which they keep asking is best marker for chronic alcoholism. So for best marker for chronic alcoholism, you have CDT. So what is that? Carbohydrate deficit transferrin. Okay. So best marker for chronic alcoholism, it is CDT, carbohydrate deficient transferrin. The last question they will ask is best marker for alcoholic hepatitis. So the correct answer here will be the ratio of SGOT by SGPT, also AST by ALT. So if it is more than one, chances are more for alcoholic liver disease and more than 2 alcoholic hepatitis. Okay, so these are some one-liners which they keep asking. So you have to be very careful as to what they are asking in the examination. So we will also do an ultrasonography, which will see the liver changes in to determine fibrosis, ecotection, and all those things for liver. Interestingly, when you do a Doppler for the liver, okay, and there is a mention of portal vein flow reversal. If this word is mentioned, this is an indirect, way to say there is systems of portal hypertension. Okay. Also, we can establish a diagnosis with the help of liver biopsy, but we know that liver biopsy is invasive. So there is another test which is also called as elastography or fibroscan, which is a good proxy for the amount of fibrosis in the liver because of the alcoholic liver disease. Okay, so elastography and fibroscan are done. They are non-invasive and done much before liver biopsy. So these were the diagnostic tests for which we should do in cases of alcoholic liver diseases. Last section before we actually move on to the treatment or management of alcoholic liver diseases is the scoring systems. So there are couple of scoring systems which are used in alcoholic patients, and each of these scoring systems will have some difference in parameters and they are used for specific purposes. So let me mention these scoring systems. So the first scoring system is Madras discriminant function, also called as MDF. We don't have to know the formula for it, but it is 4.6 into the difference in the prothrombin time, which is what is the normal prothrombin time and what is the prothrombin time in the patient plus bilirubin level. So the main thing is that if it is more than 32, this indicates a severe alcoholic hepatitis and the patient should be given corticosteroids in these cases. Okay, so this is the first scoring system. Let's look at the another scoring system also called as MELD score. So this is model for end stage liver disease. Okay, so MELD, what are the parameters it will take? So for all the parameters, all the scoring system, remember bilirubin and INR or PT-INR is constant. Here they also take creatinine level and if the dialysis was done within the last week. So based on that, if the score is more than 15, then okay, so MELD score is to decide the candidates for liver transplantation. Let's look at the next scoring system, that is GAHS, also called as Glasgow alcoholic hepatitis score. So what are the factors it will take? It will take, I have told you that all the scoring systems will take bilirubin and INR. Apart from that, it will take urea levels, WBC count and age. Okay, and if the score is more than 9, then it signifies a poor prognosis. So higher the score it is, poorer the prognosis is. The next is child pug score. So again, what are the parameters it will use? It will use bilirubin, INR, presence of ascites, presence of hepatic encephalopathy and albumin level. Okay, and based on all these parameters, we know that there are 3 classes A, B, C. A has 0.5 to 6 points, B has 7 to 9 and C has 10 to 50. A signifies compensated disease, B signifies decompensated disease and C signifies severely decompensated disease. So this is your child pug score. Last 2 scoring patterns. So the next scoring pattern is Lily's score. So again here bilirubin and PT is used instead of INR. You also have age, albumin levels, creatinine levels. Okay. So why this score is important is because it is a predictor of patients who respond poor to corticosteroids. So we will see that one of the agents which we are using, one of the therapeutic agent which we are going to use in management of this cases is corticosteroids. So if Lilly score is higher, these patients will respond poorly to corticosteroids. Let me talk about the last, and very importantly, it has been asked in recent years, that is APRI. So here what happens, we take the AST level and divide it by the upper limit of normal AST levels and multiply it by 100. So basically we are saying 100 percentage, we are calculating how much is the AST elevated divided by the platelet count. Okay. So this score is very, very important, because if this score is less than 2.5, there is minimal hepatitis. Okay. If the score is 0.5 to 1.5, there is mild to moderate. If the score is 1.5 to 2, there is significant fibrosis. And if the score is more than 2, then it is the stage of cirrhosis. Okay. So based on what score we have, so it's again a non-invasive way to grade the fibrosis in the liver rather than going for a biopsy, or before going for the biopsy. So before we end, just let's quickly look at the management. So management will be multimodal depending upon all the different symptoms, but most important being stopping alcohol consumption. Again, you may be asked, what are the medications used for de-addiction? Don't mention disulfiram. So naltrexone or acamprost. So these are the agents used for de-addiction. Also, we have seen that corticosteroids at high doses, almost 32 milligram for almost a month is used. And lastly, we know pentoxifylline. Now remember, this pentoxifylline is TNF alpha inhibitor, and we have seen the role of TNF alpha as a pro-inflammatory mark. Yes, so pentoxifylline, and this reduces the incidence of progression to hepatorenal failure, and primarily it inhibits the TNF alpha and also decreases the blood viscosity. So improves the circulation within the liver. So these are the primary agents which are used for the management of alcoholic liver disease.